We present here three examples of pancreatic duct fistulas. This first example is of a 73-year-old man who experienced gallstone pancreatitis complicated by necrotizing pancreatitis requiring debridement. Following debridement, he developed high output drainage from one of his surgical drainage catheters. The high amylase of the fluid and the surgical setting strongly suggested a pancreatic duct fistula. ERCP demonstrates this wide open fistula in the head of the gland. One cannot determine from this study if the remainder of the pancreas is missing, or if this is a rent in the duct and there remains an upstream segment not opacified by the study. A reasonable approach is to place a pancreatic duct stent. A pancreatic duct sphincterotomy is performed, and a short 5 French pancreatic duct stent is placed in an effort to provide low resistance drainage into the duodenal lumen. The second patient had recently undergone a resection of a cyst adenoma from the pancreatic body. In the immediate postoperative period, high output drainage was again seen from one of the surgical drainage catheters. ERCP demonstrates a fistula into the mid-pancreatic duct. Contrast does not fill the tail of the gland, thus we cannot determine if this has been a complete transection of the duct or simply a small defect in the wall. A pancreatic duct stent was placed, but the surgeon, because of the uncertainty regarding duct disruption, elected to proceed with a resection of the pancreatic tail, dividing the pancreas at the level of the fistula. This third patient developed a persisting pancreatic duct fistula following blunt abdominal trauma sustained during a high-velocity motorcycle accident. In this ERCP injection, the fistula is seen as a defect in the tail of the pancreatic duct. A wire is reintroduced into the catheter, and a 5 French 7 cm stent is passed up over the wire. The upstream end of the stent approaches but does not cross the region of the defect. Following stent placement, drainage of pancreatic duct fluid into the surgical drains promptly ceased. The patient returned 2 weeks later to have the stent removed. Reinjection shows no evidence of a persisting leak, and the patient's convalescence continued uneventfully. We present examples of a pancreatic duct fistula from three different locations: the head, body, and tail. The leaks developed as a consequence of three different events: following an episode of necrotizing pancreatitis, following surgical resection of a cyst adenoma, and finally following blunt abdominal trauma. The first line of therapy for management of pancreatic duct fistula is observation with the addition of octreotide, though there is no data that proves any increased efficacy with the addition of octreotide. With persistent drainage, pancreatic duct stenting can be performed. A pancreatic duct sphincterotomy with a short pancreatic duct stent may sufficiently decrease the resistance to pancreatic duct fluid flow into the duodenum and allow for healing of the fistula. It is advocated by some experts that bridging the defect with the stent, when possible, might provide added benefit. There are no studies comparing the different techniques for managing pancreatic duct fistula. The literature suggests roughly 80% of fistula will close following endoscopic intervention, but this clearly represents a selected patient population. Surgery is the definitive therapeutic option for patients whose fistula persists despite conservative and/or endoscopic treatment.